So we're going to turn things over to Dr. Sorensen, and hopefully we'll be able to hear her. And thank you again for joining us, and we have some housekeeping things we'll take care of at the end of the call. So, Bonnie?
Thanks, Ann. Can you hear me now? Can you hear me well enough?
Yes,
okay. I don't have control of the slides, so I'll let you go ahead and flip those slides so I can see the presentation.
Dr. Sorensen, I'm going to give control over to you right now.
Okay.
Let's see, I just gave you control, so now if you look on the top right ribbon, there's an arrow that says next page to the right, and if you click on that, you should be able to advance.
Not seeing next page. I don't have a next page on my screen here. Let me go up on, let me scroll up.
Virtual meeting.
I'll tell you what, Dr. Sorensen, if you just want to go ahead and start your presentation, then we can just advance the slides from here, and that will work just fine. Just let us know when we need to advance to the next slide.
Right. Well, I'm seeing the Public Health PBRN monthly virtual meeting slide right now. So if you click onto mine. Very good. This is the lead slide. It's about the use and impact of the county health rankings in Florida here. Once the county health rankings were being released in 2010 and 2011, we had a question here in Florida as to, I wonder how many county health departments are using the county health rankings, how are they using the county health rankings, and what could we learn in Florida about the county health ranking used by the county health department. So, and if you click to the next one, these are just some acknowledgments. The first 5 folks here on the page, Dr. Kukro and me, Greg and Winnie and Rebecca and Dr. Morris, were all part of our advisory group to help us develop survey questions and help us analyze the results. My co-principal investigator is Dr. Nancy Winterbauer, and we had a couple of assistants, Ben Tidwell and Nikita Walla Walker, along the way. Go ahead, the next slide. Our study objectives, as we were wondering about the county health department rankings, was to describe the ways that our counties used the rankings, also try to describe the impact of the rankings in the respective communities, and then try to understand some of the contextual factors that influence the use and the potential impact of the county health rankings in the communities. And lastly, it was kind of interesting, we were talking about this project sort of between the 2010 and 2011 release of the county health rankings, and we're trying to pull the survey together and just understand the first use. But by the time we got the survey out, the second release had occurred, so we decided we could actually ask the folks the differences in what they did in the response in 2010 compared to 2011. So we tried to describe the change in the use and the impact over time. The next slide is, many of you are aware the county health rankings were released in 2010 and 2011 by the University of Wisconsin through the sponsorship of the Robert Wood Johnson Foundation. And it was important, I think, for all of us to understand that the concept was that policies and programs would influence factors that influence health and then ultimately influence health outcomes overall. And the format of the county health rankings were such that overall mortality and morbidity were measured to reflect overall health outcomes of each county, but each county also across the country received data and rankings of the different factors that influence the health outcomes, including the health behaviors, the clinical care, socioeconomic factors, and the physical environment. And each of these factors were weighted, and each of the counties across the country were able to see their respective rankings. The next slide. This just shows the results of the 2011 Florida rankings, and on the left the results are health factor results, and on the right are the health outcomes. The darker the color, the worse the county ranked. The lighter the color, the absence of color, showed the counties that ranked the best in factors and in outcomes. And what was interesting to us when we just sort of looked at this snapshot was that our larger, potentially better endowed coastal counties tended to do better not only in the factors but also the outcomes compared to the inner counties of Florida, which tend to be the smaller and more rural counties. If you go to the next slide, this is the county health ranking logic model that the University of Wisconsin used. And the flow is such that they produce the population data and produce the county health rankings, which they expected would lead to media attention and local health departments and local health officers using the report, engaging the community about this report, which would ultimately lead in change of potential health programs and policies, which would then, therefore, lead to improved health outcomes. If you flip to the next slide, this is an illustration of really the area of the logic model that we wanted to concentrate on. The rankings were already produced, they were already released. We wanted to look at actually how the county health rankings were utilizing the report, engaging their community, and whether it made an impact on their ultimate achieving improved health outcomes. You go to the next chart. Methods, we've been working on this for really an extensive amount of time compared to what was expected. But essentially, we crafted an online survey that was administered to the local health department directors in all of 67 Florida counties. And the survey was actually launched right after the holidays of December 11, January of 2012. And interestingly, we had a 100% response rate by all 67 county health departments. And I'll have to kind of have a disclaimer here. I'm the practice-based kind of investigator here in this project, whereas Nancy Winterbauer, my co-principal investigator, is really the academician. And the 100% response rate was really possibly because of my ability to agitate my peers to respond. And I think this is kind of an interesting example in practice-based public health research where the kind of synergy between the academics and the practicing public healthers really leads potentially to a robust ability to do research. I'm able to get my peers to respond and help craft the questions, but the academic side then can help with the analysis and the final reports. In any case, we had 23 close-end questions and 5 open-end questions on this survey. So the survey was fairly extensive. The questions we actually derived from existing evaluation and survey questions. Both the University of Wisconsin and NACCHO had done surveys and had some preliminary results across the country, and we used a lot of their questions. The advisory group, our survey advisory group, helped us with the questions, and we also did cognitive interviewing of some of the individual health departments. We actually did focus groups with around 15 of the county health departments before even starting this project, and then we narrowed it down and did individual interviews with some of the county health departments as well as some of their partners in the community before crafting this survey instrument. The format of the instrument, 10 of the questions were really related to the use of the county health rankings. 7 were related to the impact, and we tried to measure not only the already achieved impact, but also the potential for impact in the future. We also had questions about, how did the county health departments value? What influencing factors were responsible for the use of these county health rankings? What their value was perceived to be, the staffing that was involved, the knowledge about the county health rankings, the community partnership sort of readiness, the amount of outreach, as well as the amount of media attention. And as I mentioned previously, since we had both the experience of the 2010 release and 2011, we also had questions that asked the county health departments to compare in all of these areas the results in 2010 compared to 2011. Go ahead, Ann, to the next one. So how did the county health departments, the local health departments, use the rankings? Go to the next slide. This is a relatively busy slide, but it shows not only the use in 2010, but also in 2011. 2010 is in the red. 2011 was the subsequent year in blue. And also shows some of the questions. How did the county health departments use the county health rankings? It's interesting that the top use by the county health department seemed to be to educate their own staff and attempt to interpret the rankings. The second most common use really was getting more information about the specific indicators. The third most common use was to give interviews to the local media as well as presentations to the community groups. We found it interesting that in issuing a press release that in 2010, it looks like around 50, some folks, 50% or so issued a press release, and it was significantly different in 2011. Less counties actually released a press release. And the next one is collaborating with community health groups to use the rankings. Again, around a little more than 40% in 2010 and a little better in 2011. And that was significant, statistically significant. They also used it by convening existing stakeholders. They used it in grant applications. They used it to create or reinvigorate a task force in the community that was interested in health. And then lastly, they developed new partnerships across sectors to respond to the report. And as you can see, the percentages of the county health departments that did that diminished down to the last use. But it is interesting when you look at 2010 to 2011, the last uses seem to be increasing. The development of partnerships, reinvigorating task force, using the rankings in a grant, and convening stakeholders. So I think that shows that the hopes of University of Wisconsin, that the logic model, that the rankings would be used to engage stakeholders and lead to impact certainly seems reflected here in Florida. Go to the next slide. We also asked the county health departments which of the sectors did their county health department attempt to engage in understanding and using the rankings, and both in 2010 and 2011. But across the bottom of the graph, you can see the number of the types of sectors we asked them specifically about. Employers and businesses, healthcare professionals, community opinion leaders. Interestingly, the government officials were the most engaged, not only in 2010, but also in 2011. We were a little surprised by the healthcare professional engagement. It was less than 70%. It seemed logical to us that the most outreach would have gone to healthcare professionals, but was not. Other groups, community groups, local schools, local universities, faith-based communities, and other groups that they thought about that we didn't think about and didn't include in the survey. The local universities is interesting. In 2010, it appeared there wasn't as much outreach to local universities as there was in 2011. And it's also interesting that employers and businesses seem to get more outreach in 2011 than 2010. So the employer and business and local university outreach was different in 2011 and significantly increased over 2010. We did see increase in faith-based community outreach and other community groups and local schools, but that was not significantly different between the results in 2010 and the results in 2011. Go to the next slide, Ann. The assessment improvement, we wanted to understand the use of the rankings in community health assessments and in community health improvement plans, the CHIPs. So we asked, has your county health department already incorporated the results of the rankings in your most recent community health assessment? Interestingly, 59.4% said yes, and 14.1% said no. We asked secondarily if your county health department had not recently or not completed a community health assessment since the rankings were released. Do you intend to incorporate these results from the rankings into your next county health or your community health assessment? And 23.4% said yes, while 1.6% said no. So all in all, we were pleased that between the two already incorporated or intend to incorporate, it was almost 75% of the county health departments said yes. And what's also interesting is the 15 or 16% who said no, it was really a very hard no. Folks had the county health rankings and definitely intended to not use the ranking in their community health assessment, which was just kind of an interesting comment. Why don't you go to the next slide? In the open-ended questions, we asked folks, besides the uses that we asked them specifically about, were there additional uses that they had for the county health rankings? And these are just some of the comments explaining their mission to employees, which is interesting. They shared their rankings with their internal staff via newsletter and internet, op-eds, dialogue with legislators, discussion points with specific partners. In the development of a community balance scorecard, they used the rankings. They used the rankings for budget discussions with county commissioners and other leaders. They used the rankings for new education and promotion, health, wellness promotion programs being developed around the lifestyle factors. And one county commented, we used our low ranking in terms of healthiness and communicated it to the county government, city government, and county school board. You can go on to the next slide. The next series of slides really has to do with what influences the use of the rankings, what kind of aspects of the county health department influence their use. And the first kind of influence or background contextual feature that we want to know is about their knowledge about the county health rankings. So we asked them how knowledgeable they were, or if they had delegated this project to another member of their staff, how knowledgeable was that staff about the county health rankings. And again, very knowledgeable is in blue, somewhat knowledgeable is in red, and these were the scores. We asked them if they understood the logic model of the rankings, and about 25% said they were very knowledgeable, another 50+% said they were somewhat knowledgeable. We also asked them specifically if they were knowledgeable about how the rankings were computed. And again, about the same results, 20+% very, and over 50% somewhat knowledgeable. We asked them also about the specific measures in the rankings, and again, they seem fairly knowledgeable. The key messages about the rankings sort of on the University of Wisconsin website, the messages to use with the media, they seemed quite knowledgeable about that. We asked them if they were knowledgeable about engaging the stakeholders in the rankings, as well as how to move the rankings into action. And again, although less than 50%, they were on total very or somewhat knowledgeable. It is also interesting to us that compared to very knowledgeable, the somewhat knowledgeable was a little larger. But we felt that the combination of very knowledgeable and somewhat knowledgeable was really quite positive amongst the county health departments. Go to the next slide. We also asked them details about how they staffed, which staff, and how much time they spent doing kind of internal work in preparation for utilizing the county health rankings. So we asked them how much time was spent trying to understand, interpret, and in planning a response and then responding to the county health rankings. We were a little disappointed in these results. 3.1% of counties reported that they spent a substantial amount of time. 45.3% said a moderate amount of time, but 45.3% said they spent minimal amount of time, and 4.7% even said they spent no time on this project. We also are interested in the use of the University of Wisconsin website, and again, we were a little disappointed. 15.6% said they did spend a moderate amount of time on the University of Wisconsin website, but 73.4% said minimal amount of time, and another 10.9% absolutely didn't even use the University of Wisconsin website, which to us is quite remarkable, considering all the publicity and efforts that were put out by the University of Wisconsin to educate the local health department. We also have quite a bit of support in Florida internally with data, and we asked them, therefore, how much staff time did they spend actually seeking internal support from the state-level office about their rankings and technical assistance. And 1.6% said substantial, 10.9% moderate, 71.9% reported minimal time spent in trying to seek technical assistance from the state office, 14% zero. So this was quite surprising to us overall, the amount of energy, I guess, that was spent on the county health rankings by our county health departments. Would you go to the next slide? We also tried to measure how valuable the local health departments felt that these rankings were. And these are the results. 58 of the health departments, which is 90%, reported that the rankings described their county health status very well or somewhat well. 47 of the 67, i.e. 73%, strongly agreed or agreed that the rankings were a valuable resource. 47 of the 67, or 73%, strongly agreed or agreed that the rankings improved their ability to garner attention, which is, I think, a positive aspect of the use of the county health rankings by Florida. And in light of the previous chart, that they spent very little time, may mean they're very smart and they intuitively knew what to do and how to do it, because they certainly seem to value the county health rankings, despite the fact that they didn't spend much time getting knowledgeable about it or support about it. Go to the next slide. We also delved into what they valued, and these were the results. We were quite surprised that the health departments reported that they liked the idea that they were ranked. I think our state office has always been a little reluctant to tell one county that they're better than another county in anything, so we were quite surprised that the counties actually enjoyed being ranked. And I don't know if that's a trend across the country. Normally, ranking becomes quite personal, and most folks don't like to be ranked. But our county health departments reported that they thought that was a positive aspect of the county health rankings. They also reported that the use of the ranking as a communication tool was very valuable. It allowed them to speak about the public health system and the social determinants. They also felt that it was positive that it did lead to a call to action. They also felt it was valuable because it came from an external respected source, University of Wisconsin and Robert Wood Johnson. And the smaller counties commented that they felt that it was a great resource for them because of their lack of internal resources. Go to the next slide. These are just some of the comments that we recorded in the open-end questions. Rankings provide a concise snapshot of a county's population health. It showed how low or bad our county was relative to the rest of the state. Go to the next one. Comments about the communications aspect of the tool increases awareness of the broad scope of public health system far beyond. And secondly, much of what influences how healthy we are and how long we live happens outside the doctor's office. Some factors are improving in our county while others are clearly warning us of future health problems. The next one. Comments about the value related to the call to action. The county health rankings are a call for communities to work together, develop programs and policies. The rankings let counties see where they are doing well and need to improve. And then secondly, enable us to focus on zip codes in our county suffering socioeconomic deprivation in order to lead the community in assessing and developing improvements. And the fourth one is their comments related to external and respected source conducted by well-respected research entities outside the arena of county health departments. It was an independent document, not generated within the department, i.e. credible. In the next slide, comments about the use as a resource useful for small rural counties without resources to generate this type of document, and attention was called to the public health even in small rural counties. If you go to the next slide, these are some of the issues that were brought up in a negative way about the county health rankings. Some of the county health departments felt that the data was too old, that there was better local data available, and someone commented that it obscured pockets of need. I guess in a larger county, since it was countywide, it was really just a countywide document. Other counties felt that they had the lack of capacity to utilize the county health rankings, and other counties, interestingly, commented that there was a lack of community interest. And if you flip the next slide, these are some of the open-end comments. I do not find the rankings useful as far as data is concerned. Data are at least 1 and often more years old. I find similar data in our Florida chart system and use it regularly. It lacks comparison, but is more timely and more easily digested by my audiences. And from year 2010 to 2011, some of the indicators changed, which made the differences more difficult to explain to the community groups and media. It would have been beneficial to use the same indicators from year to year. The next slide is comments about the use of the data from a capacity perspective. We are small, have experienced significant cuts, we have no capacity, state and county budgets cuts, depress the county. These financial factors will inhibit options for change. Very small county, no ability to use the rankings, the funding situation is so tired, we can barely deliver core programs. Go to the next one. And these are kind of the interesting open-end question or comments about community interest. There are no barriers to using the rank. Getting attention and generating action are two different items. We tried very hard to get the Chamber of Commerce and Business community interested, blah, blah, blah. The largest barrier is lack of community focus on public health issues. And lastly, community partners and stakeholders give only a cursory glance to data. Go to the next slide. The next series of slides really reflect how the rankings impacted the communities and community health promotion efforts. Go on to the next. This was a question about, have the county health rankings already produced the following outcomes in your county? And out of an N of 64, you can see the percents are fairly small in already impacted, increasing public health awareness of multiple factors, increasing public awareness of the broad scope of public health, promoting local programs and policies, influence the development of community programs, influence the adoption of new policies, influence the allocation, and leveraging additional funding. All of these are less than 20%. Go to the next slide. This is the question of sort of looking in the future. Are the county health rankings very likely or somewhat likely to produce the following outcomes in your county in the future? again, the same questions, but the percentages look significantly better, almost up to 70% in the first 5 questions about increasing public awareness of the multiple factors and the broad scope of public health and promoting local programs and influencing development of community programs, even the adoption of new policies. So given the already impact and the likelihood of impact, again, we interpreted this as being really a positive reflection or alignment with what University of Wisconsin and Robert Wood Johnson was looking to happen, that there would be impact based on the county health rankings. Go to the next slide. We were looking also at what influences the impact of the rankings, and these are just a series of questions and quick slides. Go to the next one. This question was, what was the amount of attention the rankings received as a result of their first release in 2010? The blue is quite a bit, and the red is a moderate amount. And this does not include media. We have media separate, but these were the amount of attention that the healthcare community paid, policymakers, other community groups, and the general public. And it was a little disappointing to us, especially in the healthcare community. They added the 15% plus 35%. It was really a total of 50% was either quite a bit or a moderate amount by the healthcare community, and it was quite similar to policymakers and other community groups, and least of all, the general public. Go to the next one. This question is, what type of attention did your agency receive as a result of the first release in 2010, with blue being mostly positive and red being somewhat positive? And again, it looks somewhat similar. Healthcare community, about 55% mostly and somewhat positive. Policymakers, 15 plus 30, about 50% positive. Community groups, quite similar. And the general public, less so. Go to the next slide. This question was more specific to media. And we asked, what was the amount of media attention to the rankings received as a result of the first release? And the reason we asked this, again, because of the logic model. The logic models suggested that once the results were released, that it would gain media attention and community engagement, and that would lead to the ultimate outcomes. So quite a bit of media attention, almost 15%, a moderate amount of attention, 40%. And again, that was a little surprising to us because we saw the media and we thought there was quite a bit of media, but the other smaller counties probably were neglected by the media compared to the larger counties. Go to the next one. And the amount of positivity, what type of media attention did your agency receive in 2010? Mostly positive and somewhat positive. Overall, less than 50%, but as opposed to receiving negative attention by the media. So go to the next slide. This is the kind of series of slides in which we're trying to look at what changes have occurred over the time between 2010 and 2011 in the ways that the county health departments have used the rankings. If you look at the next slide, you can see the difference in percentage of county health departments using the county health department rankings 2010 compared to 2011. The green lines are those that are statistically significantly in the positive. The red is statistically significant in the negative. So you can see that creating or reinvigorating a task force to discussion was changed, that it improved over time between 2010 and 2011. Developing partnerships across sectors was also improved from 2010 to 2011. Collaborating with community groups improved from 2010 to 11. Convening existing stakeholders, giving presentations, and the use of rankings in a grant and getting more information pretty much stayed the same between 2010 and 2011. Giving interviews to the local media seemed to decrease, although not significantly, and issuing a press release. Again, less press releases were released in 2011 than in 2010. Go to the next slide. This is a slide about the engagement 2010 compared to 2011. The difference in the percentages of county health departments using the county health departments, the county health rankings with employers and businesses, local universities, faith-based schools, other groups, community opinion leaders, government officials, and healthcare professionals. And again, you can see the statistically significant changes from 10 to 11 are in green, more outreach and more engagement of employers and businesses and local universities compared to actually a negative, not statistically significant, but a negative, less engagement with healthcare professionals. Go on to the next one. We were also interested in the change in media attention between 2010 and 2011. So we asked about the amount of media attention they received. Did it increase? How many thought it increased, decreased, or remained the same? Almost 30% said it decreased from 2010 to 2011. 50-some% said it stayed about the same, and paltry, really less than 20% said it increased, which I think is something that needs to be thought about since it's part of the logic model. The more media attention, potentially, the more more outcomes that can be achieved. And when we see that it really did not increase overall, it stayed the same or actually decreased more than it increased, that's something that we're going to have to deal with in the future. Go to the next slide. From a discussion perspective, so far we've done mostly quantitative work with the survey. We are in the midst of doing case studies. We interestingly noticed when the county health departments answered the survey, we sort of hypothesized that we thought that the county health departments who were in the top quartile of the rankings wouldn't have a lot of use and a lot of work to do, whereas the county health departments that were in the bottom quartile of the rankings would be doing a lot. And we kind of were looking for that. But what we found is that some counties who were in the top quartile did a lot of outreach and a lot of engagement, other counties doing less, and we found that some of the county health departments who were in the bottom quartile did nothing, despite the fact that they were in the bottom quartile. So we've had interviews with 6 of those county health departments who were either top quartile and high outreach and engagement or low, and those in the low bottom quartile. We've had discussions with those 6 county health officers, and then we've gone further, and we're in the process of interviewing their stakeholders, a half a dozen or so of their stakeholders, to understand what is really kind of the context within which the county health departments are utilizing these county health rankings. We know they're using them. We know how they value them and how knowledgeable they are, but we felt there's more that's going on in the community that explains why top quartile counties would be overly engaged or underly engaged, and same with the bottom quartile. So from a discussion perspective, this just is a discussion, kind of our thinking, based on really the survey results, without the results of the case studies that we're doing. But certainly the rankings seemed important, and I think that's an important lesson here. I think also the fact that the media attention seems to be declining is something that needs to be discussed. Also, the lack of interaction of the local health departments with the University of Wisconsin or with the Florida Department of Health's support system is remarkable. And then also the discussion of the smaller counties not having the capacity to kind of engage and outreach and do anything with these county health rankings is another discussion point. If you go to the next slide, we're thinking about implications of this study. The implications for the Florida Department of Health is that we would suggest that the Florida Department of Health needs to be more active with the county health departments in trying to generate media attention, giving the county health departments more expectation to work with the media. We also think the Florida Department of Health needs to be better engaged with those rural, smaller counties that don't have the capacity. And we also think the Florida Department of Health could be more active from a technical assistance basis related to the data that's used in the county health rankings. Florida does have more current data, but the local health departments may not be able to really understand that and plug in different numbers to see how it might impact the county health rankings. The implications for Robert Wood Johnson, I think, are going to come more out of the case studies we're doing, trying to understand the community readiness, or what is it about a county that really takes the county health rankings and launches a community effort to try to improve health compared to other counties that don't. And those results really will be pending and will be in the future. So I think I have a last slide that just says thank you and my contact information. And with that, I'll turn it back over to you all.
Thank you, Dr. Sorensen. That was a really fascinating presentation. It sounds like you've found out a lot of interesting things, and you've also raised some questions to pursue down the line. If folks have questions, we'd like to ask them to type something in the chat box, and then we will make sure that you are unmuted and call you out to jump on in. So are there any questions for Dr. Sorensen yet? Well, I'll get the ball rolling. I was wondering, on your slides where you're talking about attention, a lot of folks talked about quite a bit of attention and moderate amounts of attention. And we were wondering how, if you provided any quantitative guidance for answers on those questions, if the respondents were told what might constitute quite a bit, or if it was largely a qualitative, subjective sort of assessment.
Yes, it was largely qualitative. In some of the questions when we said substantial or moderate, that was left up to the discretion of the local health departments. We didn't give them any criteria about how much, for example, in asking about staff time. We thought about giving, oh, you spent an hour, you spent a week, we just decided to leave it up to the county health department, so it is quite subjective.
Thank you, that helps a lot. Anyone else have any questions for Dr. Sorensen? All right, I'd like to thank you once again for a terrific presentation, and I'm sure we'll be following up with you. Actually, our communications folks are on the line. We're going to hear from them in just a minute, and I bet they're going to want to talk to you for some newsletter issues. So we'll talk really soon. Thank you so much. As you move on to your next slide, thanks again to everyone for joining us today. We have a few other agenda meeting items. As I mentioned, we are very lucky to have on the phone today our communications folks here at the Coordinating Center, Kara Richardson and Vicki, and they are going to talk really quickly about the website. I know we've only got them for about 15 minutes, so one of the things that has come up over and over again is we've looked at our Keeneland grantee meeting evaluations, as well as some things that we heard personally at the meeting had to do with how we could make the website more functional and more helpful for the grantees and the affiliate networks. And what we really want to do is hear that and take action on as much of it as we can. So I'm going to turn this over to Kara and let her speak for just a few moments. Thanks.
Hi, Anna. Can you hear me?
I
can. Okay, good. I know Vicki's on the line too, and we have officially turned the button, flipped the switch on our new website, which is stillpublichealthsystems.org, and we have a specific section on the navigation that you'll see is listed as PBRN if you visit the site. Once you're there, there's several different things there's information about the staff and the National Advisory Committee, and we're beginning to flesh out the pages that are underneath. But what I'd like to do is hear from the PBRN community, hear from the people that are actually out there using the site and coming here for information on, one, examples of other sites and websites that you like the navigation or like the content, general design, and as well as once you've looked at the new site and feedback that you have on the old site, which is now, it's back in the archives now. You can't actually access those old pages. But if you can send that to news, which is NEWS at publichealthsystems.org, then we'll start to compile those. And, what we can do within the next, couple of months, we will. Otherwise, we have phase 2 starting in probably in about 6 months. We'll start looking at some other things, ways we can add interactive elements, more searchable databases, and those kind of things to the website to make it functional for the PBRN community. So now that I've said that, I can hand it over to Vicki and let her kind of say hello and go from there. Vicki, are you on the line?
I don't see that Vicki is logged in, Kara.
Okay, I know she's on the phone. I was just in her office, so okay. She may have already had to go. I know.
Let's make sure that we don't have a call-in user muted that doesn't have a name attached. No, I do see her name logged in on the video, but not on the audio right now.
Okay, all right. I think she probably has the same kind of request from everybody that we do, and there's also, we've been working on newsletter templates to send out. We have a PHSSR newsletter and a PBRN newsletter that will go out. There'll be some overlap between those, but what Vicki does is she collects everything by or before the 15th of every month, and then we send out our newsletters, at least the PHSSR newsletter, we send out on the first week of the month. So if you have news stories from your communities or things that you like to share in the PBRN as well as the PHSSR newsletter with the communities, feel free to email them. Her email is Vicki, VIKKI.Franklin at uky.edu. So you could send it there or to the news at publichealthsystems.org, and we'll get them to the right place. So we appreciate it. We look forward to your feedback on the new website. So.
Thank you, Kara, and we really do want to encourage people to use those dissemination tools. Those newsletters are very important for sharing our information internally, both within the PBRN network and to the broader PHSSR community. So we want to make sure that the good work you're doing is getting out there and that people know about it so that we can continue building our network. Does anyone have any questions for Kara while we've got her on the line? We'll just open up the floor for just a couple of minutes. Again, if you have a question, just jump right in there.
This is Vicki. I'm sorry I somehow managed to disconnect myself, guys. I apologize. Obviously, Kara's better at technology than I am. I was just going to echo what Kara said in terms of we've done the best we can in providing the resources that we think you need in a way in which you need them, but you're the experts, so tell us what's working for you, what's not. As with all websites, it's a work in progress. This is a start, and we would love to hear from you about whether the resources that you want are there, where you need them to be as easily accessible as possible. So please now, later, whenever, take a look at the website and let us know your thoughts. We appreciate it.
And thanks to Vicki and Kara, they've been working really hard on that website. They've been working with a lot of different constituencies, trying to keep a lot of people happy. So I know that it's a lot to ask of anyone, and we really appreciate all they've been doing. But the website can only be as functional for you as you let us know to make it. Because if we don't know that a certain functionality is something that you need or something that you would like to see, then we can't really incorporate it. So if there are things that you know that you would like to see on that website, please send us an email. You can send it to me at anna.hoover@uky.edu, or you can send it to the Public Health PBRN account if you didn't get the email addresses that Vicki and Kara provided earlier, and we will make sure to get that information to them. We really want to make sure that the communication processes that we are establishing here at the NCC are the most effective for you and help you do your job better and help you make sure that the information about the research that you're doing is getting out to the important stakeholders. Moving on along down the line with some other issues that were identified at the grantee meeting. As you know, Lizette had been on the job 1 week and I had been on the job 2 weeks when the grantee meeting was held. So we've now had a chance to get to know things well enough to process some of the feedback. And we've been working closely with Glenn, and we heard a lot about quick strikes. So I just wanted to update folks on the quick strikes for this year. Everyone who has submitted a quick strike should have received a response by now. If you have not, send me an email or send it to the Public Health PBRN. You should have received at least an initial response to your application. We're planning to do 2 more rounds of Quick Strike reviews this year. One will be at the end of July, and one will be at the end of August. If you want to do a Quick Strike and finish it by the end of May 2013, then you need to have your application in by July the 15th. So if you have any questions about that, give us a call. If it's in by July 15th, it will make that July review period, and then if it is funded, then it can be finished by May. If it is not in by July 15th, we'll work it into the August review. We're also trying to implement some processes that will maybe make Quick Strikes go a little quicker and a little smoother next year, and for sure make your notifications get out sooner. As you know, the moving of the NCC sort of threw a glitch in some processes that had been established just because of the lack of personnel. So we're now just really trying to get that and get that clicking on all cylinders. So if you have any input on that, again, please let us know. You can email me, you can email Lisette, or you can send it to the Public Health PBRN program. Now that I mentioned Lisette, another question that came up at the grantee meetings was, who do we contact for what now that we have a staff at the NCC? So we're going to answer that question really quickly. Lisette is going to be handling financials and RWJF process-related questions. So if you want to know something specific to your grant, who you need to contact, when something is due, what kinds of paperwork you need to do, Lisette is your one-stop shop for that. And if we don't have the answer, because again, we're still sort of learning the ropes a little bit, we will track it down for you. If you have questions about cross-network collaborations, if you have questions about communication, dissemination, research translation, or opportunities for funding diversification, grantsmanship, any of those kinds of more research and translation and dissemination-oriented questions, please feel free to contact me. That's anna.hoover, again, at uky.edu. We are right next to each other, so if you ask one of us a question that she can't answer, she will certainly ask the other person and get you an answer. So please understand that whatever question you have, we'll find you an answer, but folks wanted to know who to contact for what kinds of things, so I wanted to make sure that we were clear on that, and I hope that was clearer. We also had a request from Sarah Ramirez, who is one of our many grantees from California, to talk a little bit about sharing information and methods to address health disparities. I don't see Sarah logged into the call, but we do have some call-in users who are identified by numbers right now rather than names. So I'm just going to open it up, and Sarah, are you on the call? All right. We will just reschedule that for another time and make sure that those issues that she wants to talk about do get addressed. We also want to recognize the 40th year of Robert Wood Johnson Foundation. They started in 1972, which is, funny enough, the same year that I started, 1972. And they started out with a $1.2 billion endowment, and look at what they've done with it. They are right now soliciting some stories on their website, which is at www.rwjf.org/40years. I think they're looking to tell the broader story of how they have made an impact on health in this country. So if you have stories from your community, from your PBRNs, from your research that you think they might like to hear, by all means go to that website and submit your story. I think they're also doing a young leaders under 40 or 40 and under. I can't remember exactly how it works, but they're also soliciting some nominations for that program, so you might want to have a look at that. Also at the rwjf.org/40years website. So again, we just want to say congratulations on 40 great years, and we're looking forward to working with you for the next 40, at which point I will be retired by the end of that. We have some other information to cover. Oh, we do have a quick question here. Let's see. Quick Strike proposals for August review have to be in by August 15th. Is that correct? Yes, please. That's from Susan Zahner. We would like to get those in by August 15th. And when should August Quick Strike proposals be complete?
Maybe the review.
The review, I'm not sure on that. Hopefully we'll get the review in and out the door within about 3 weeks and get back to you within a month. That's my goal. I will let you know if that's going to change at all, but we're going to shoot for that right now, as quick a turnaround as we can, and get the information back to you within a month. And again, we apologize to those of you who were left waiting for a little while we got staffed and up and running, but we're hoping to keep that from happening again. So July 15th, if you want to complete your quick strike by the end of May, August 15th to make the May review, or to make the August review. And any questions about that, do just let us know, and we'll do everything we can to make that a smoother process for next year. Are there any other questions related to any of those housekeeping items before we move down to the dissemination list? When should the projects be completed? It's an 18-month timeline.
That's right, 18 months.
So if you, let's see, the end date for the August reviews. Let's see, August to August would be 13 months, and 5 more would be September, October, November, December, January. So they would have to be in by, I think, January. I think the May, finishing up by May, was something that Glenn had said that I think has more to do with the end of the TAD proposal year and all of those things. So let me double check on that, Susan. Let me just make sure that I am giving you the right information and that it's 18, because suddenly I'm thinking it might be at 6 months on quick strikes. Let me look that up and shoot you an email, but I believe that might be a slightly shorter timeline. Again, we're just sort of getting our legs under us here, and we will get those answers for you. And we'll probably just send out an email blast to the whole group. I think that'll be the way to do it from the Public Health PBRN account, just to make sure when those end dates will be for the August reviews. Any other questions related to the quick strikes or to the website or any of those things before we move along? Okay. Items for dissemination, the special PHSSR issue of the Journal of Public Health Management and Practice, which will have a PBRN focus, will be released this November. So keep an eye out for it. It's going to come out about the same time as APHA, so I think that there's some plan to make those happen around the same time and launch it publicly in that area. Frontiers in PHSSR, the open access journal that we're using to try to get our PHSSR and PBRN research out there as quickly as possible to practitioners, is online. We launched that at the grantee meeting, and I'm sure that you remember that discussion. And we invite you to visit it. We also invite you to submit if you have research results that you would like to get online. We would love to get those out there. So by all means, please submit to Frontiers. If you have any problem doing that, give us a call, and we'll talk you through it. Also, you may remember from the grantee meeting that we have the REACT podcast series that Dr. Paul Halverson will be hosting. That is in production now. He has some recordings in the can from Keeneland's conference, and he's going to be making some more interview recordings next week at Academy Health. I know a lot of you are probably heading that way, so you may see him running around with a digital audio recorder. Say a few words to him and tell him about your work if you can. We'd love to get a lot of good information from our PBRNs to highlight in those sessions. So REACT should be launching around the end of August is the goal. Other meeting agenda items. You all know about the upcoming meetings. Academy Health, I don't know how your offices are, but right now we've got everyone scrambling around printing posters and getting on airplanes, getting ready to head that way. NACCHO is going to be in July, the 11th through the 13th in Los Angeles. And of course, APHA is coming up this October in San Francisco, and I look forward to seeing you all there. July events, we're going to have a monthly virtual meeting on July the 19th, and that's going to be a presentation by the Colorado PBRN. Lizette has been working with that PBRN to pull together the information for that presentation. We're really looking forward to it. Also, we'll be doing a quarterly skill building webinar at the end of the month. That will be on July the 30th from 1 to 2:30 p.m. And the topic's going to be preparing participatory grant proposals. A lot of you are already doing very engaged kinds of work in which you're working with community organizations, and we're looking at ways that you might be able to diversify your funding portfolio through the work you're already doing by pursuing community-based participatory grants. And I've reviewed a few of those in my day, and I'm going to talk about it from a grant writer's perspective, a grant reviewer's perspective, and hopefully give a few tips on some things to include and not to include and to make sure you hit on. So I hope you'll tune in for that on July the 30th. If you have any ideas or any specific questions that you'd like me to answer in that, be sure to shoot them to me via email at my address or at the Public Health PBRN address. I want it to be as focused on your needs and your questions as we can make it. Also, we have an update from the Ohio Public Health PBRN who would like to do who are doing a survey that they would like to talk to you a little bit about. Are you guys online?
Michelle is here. I see Michelle there.
Michelle?
Hi. Yes.
Yeah.
Hi.
Michelle,
Actually,
I'm sorry.
Oh, yes.
I have some of your slides are up after this, so I'll let you talk about your slides and you can tell everybody what you're wanting to do. Before we continue, I would like to remind everybody, I know that we have network contact rosters. Each PBRN has a roster of their active members. We would greatly appreciate if you send those to us at your earliest convenience. We're trying to update our files and make sure that our communications are all in order and everybody's getting what they should be getting. And so we really encourage all PBRNs to please send us your updated network contact roster.
All right, thank you, Lisette. And now, Michelle, we're going to turn it over to you. I'm going to advance to the next slide somewhere. There you are. All right, go right ahead.
Hi, this is Scott Frank here with Michelle Menegay in Cleveland, introducing the group to the idea of participation in a project we call the Future Teaching in Local Health Departments. This is a project that looks at the decrease in resources in local health departments, which we look at in our PBRNs in so many other ways, but in this case, specifically addressing the issue of whether that decrease in resources is going to influence their ability or willingness to do teaching of students in the local health department setting. Part of this is to recognize that local health departments are not in any way restricted to contact from public health programs, but many other academic programs may be contacting them and recruiting opportunities as well. So, for example, the survey looks at the breadth of different programs that might be approaching them, not just graduate public health, but undergraduate public health, graduate nursing, undergraduate nursing, environmental health, health education, nutrition, public policy, and many of the health departments even have high school students come in and do shadowing. So it gets a sense of the full spectrum of teaching that they are doing, and for each of these there may be 5 or 6 different formats for the teaching, from practicum to capstone to paid internships, unpaid internships, independent studies, and so forth. So looking at both the type of student and the nature of their the teaching that occurs within their setting, which of those is value added to their health departments as opposed to which experiences primarily draw resources without adding value, is part of what we'll be looking at as well. This project is in the field in Ohio. Do we have another slide?
yes. Can we?
Great. So this project is in the field in Ohio. We're hoping for local health directors or health commissioners and or division directors to complete the survey, and we're looking to see whether there are brother PBRNs who are interested in having the survey distributed within their PBRN. If you're interested in doing that, we will have a broader convenience sample to report on, and we are committed to giving you the data from your state. We'll look at it in aggregate, but feeding back the database from your state to you to do with as you will. If you can go to the next slide. The commitment that we're looking for is collaboration to recruit participation in your state PBRN through your marketing, the survey link to local health department leaders via email blast, conference calls, other network mechanisms that you use for communication routinely. Other thing that we would need from you is a denominator information that allows us to estimate the participation rate. And the advantages is that we will make the database available to you, and there would be opportunities to collaborate on analysis and publication if anybody's more interested in this particular topic area. The contact information is here if you are interested in participating. If you'd like to review the survey, the link is on the presentation as well to review the survey. If you have thoughts or suggestions about the survey, we're happy to listen to them. It is a longer survey rather than shorter. This is a depth look at the topic, but happy to take feedback and listen to thoughts before we move this from Ohio to a national participation. So thanks for listening. Happy to take any questions.
Thank you, Scott. Dorothy has asked if we could put the survey link up again, so we've backed up to that slide. You can see it right there. Also on the slides, a couple of slides ahead is the sample solicitation letter, I believe.
Correct. The email that we sent out to the Ohio network, we have as, I believe, the third slide in this little series. So this is how we recruited Ohio health departments to participate in the project. The intent would be to have this as a case project so that the IRB is only from here rather than have it disseminated. We will be doing an amendment that includes each of you who would like to participate, a letter of agreement for participation, and we'll solicit from you within that letter of agreement the information about how you will communicate with your network, and that's all we'll need for the amendment to our IRB here.
Does anyone have any questions for Scott?
Yeah, hi, this is Elaine from the Connecticut PBRN. Sorry I signed on a little late, but how are you, Scott?
Good.
I had just a couple of questions. You may know if you're. Do you have a public health training center that you work with at all, Scott? In your area?
It's based at Ohio State, the Ohio Public Health Training Center.
Well, the reason I mention that is that, as you probably know, the public health training centers now have as part of their mandate these student learning projects, and including field placements and so on. And HRSA's emphasis is governmental public health. So this is, I'm thinking that the public health training centers would be interested in this survey and in getting a better idea of the current capacity of local health departments to do this mentoring work. You know, we realize that local health departments benefit from having students, but we also appreciate the work involved in doing that. But so that one thought is that perhaps you might want to check in with public health training centers to see if that would help increase your survey.
That's a great suggestion.
But also, Scott, I'm wondering why, because when you said it, I thought, well, you know, we would possibly do this in Connecticut, although I don't think Jennifer's on the line. But I am so loath to hand another long survey to people. We've done 3 studies this year of local health departments. Why did you, and I haven't seen the instrument, why are you going for a longer survey? Maybe if I looked at the instrument, it would be obvious, but the topic just seems that one that could be investigated with a few questions. But
well, it has been investigated with a few questions, so we're looking to look at it in more depth. We're also looking at making the relationship between a decrease in resources with changes in capacity to teach. So, you know, there's a set of questions that's basically NACCHO-based regarding changes in resources in the health department, so that's part of it. But the other thing that we've heard from the local health departments as we've discussed moving this into the field is don't just ask us who we teach, you know, about public health teaching, because that's just a portion of what we do. If we're only asking about that, we're missing the point. So in order to ask about the breadth of different disciplines that are approaching health departments, and in order to address the breadth of different experiences within those programs, it needs to be longer.
Okay. So what is your timeline for gathering the data?
Excuse me. I would say that at this point it's a flexible timeline. It really depends on what kind of response we get from the other PBRNs in terms of whether they're interested in being part of this and disseminating the survey. I will say that in parallel to your comments about the Ohio Public Health Training Centers, as we've talked about this idea and implemented it in Ohio, we have really every public health organization coming to us and saying, we really want to hear the results that you get from this, from HRSA to CDC to APTR to APHA. There's a high level of interest in this topic, as you can imagine, because it, you know, there are competing forces. At the same time that we are having more and more students in public health, and at the same time that the emphasis on practical education in public health has increased, we have decreased resources in the local health departments that would do that teaching. So this mismatch is really the motivation for doing the project, and the more participants we can get, the greater generalizability we would have in communicating the results.
Yeah, and I would imagine that the ASPH is also interested because of the academic health department model aspect of this subject. But so again, I'm sorry, Scott, I don't want to take any more time. I'm sure others have questions, but so the survey is here to be found. We can look at the survey by going to this website? Or?
Correct. This is not the survey that is in the field in Ohio, so you can actually take the survey as if you're a local health department director. Many of you know I happen to be a local health department director in addition to my role at Case Western, but you know, you can just answer as you imagine a local health director might, and time yourself on it to see how long it takes you to do it. Generally speaking, 10 to 15 minutes is what we've heard. I think the question tends to be when people don't know the answer to questions. They can complete it more quickly by just not responding to that item, or they can go and find out that information, and if they have to go find out the information, that's when it would begin to take longer.
Okay. All right. Thank you.
Thank you. Are there any other questions for Scott? All right, I guess hearing none, we're going to have a little bit of fun with the slides and go back a few slides, because there are a couple of things that I want to be sure to cover. And I do want to thank Scott again for talking about the survey, and if anyone has any questions, contact him directly, or you can always contact the NCC and we can help facilitate those connections. Going back a couple of slides, we want to point out a few other resources for you. In terms of your grant reporting, these are the email addresses for you to send your grant reports to at RWJF, and then be sure to copy us on them so that we know that they've gone in, so that you won't be getting emails from us saying, did that go in? We appreciate that very much. The guidelines for annual final narrative and reports and bibliography are on RWJF's website. Right there is your link, as are the guidelines for financial reports and the guidelines for electronic submission standards for products and reports. We've been spending a lot of time on the RWJF website learning the ins and outs of it, so if you have questions about it, give us a yell. We will figure out an answer for you. I also want to reiterate what Lizette said earlier about the network contact rosters. We are doing our best to set up as efficient and functional a national coordinating center as possible here. We want to make sure that we are providing you with the best service possible, but it helps us if we know exactly who we're serving and in what capacity. So if you can get us those updated network contact rosters pretty soon, that'll be great. Lizette, did you have anything else we need to cover?
I think that's it.
Does anyone have any questions or comments you'd like to make?
Well, are you going back in the agenda right now? Is that what you said? I'm sorry.
Oh, no, we went back a few slides before the Ohio slides. They got out of order. We had a couple of late-breaking changes just before Glenn got on his plane, so we had to reorder the order of things, but we did not get a chance to reorder the slides. So just went back to the earlier slide on grant reporting reminders.
Okay, so I don't know if this is out of order or not, but I just had a couple questions from other things that were on the agenda when you were running
Sure,
through.
that's fine.
You sure?
Yes, sure, absolutely.
What is do you have plans already for APHA?
Plans in terms of, we do have space reserved for a meeting. We haven't scoped that meeting for what it would cover or what it might do. It might be related to improve, or it might not. We're still working on that. We did reserve the space to hold it. So we'll be getting back with you on that shortly. As you can imagine, Glenn's travel schedule this month is a little bit crazy. So when we all get a chance to sit down and talk, we will work up an agenda for that and get it out to everyone.
We have the Connecticut Public Health Association has a conference in October, also at the beginning of October, and we're going to have a panel on the Connecticut PBRN, and we'll have, we'll talk about the PBRN model, but also talk about the preliminary findings from the 3 studies or 4 studies that we're working on. And I wanted to do an introduction on PHSSR, and I didn't know if there was anything more current. Len had shared some slides with us before that I could access to use for a presentation. And also, if we could, if we videotape this, we could certainly share the panel presentation.
Well, that sounds terrific, Elaine. We'd love to do that. We can talk about that after the call, maybe making it even available online to our logged-in registrants and all of that sort of thing. But you do bring up a good point that if anyone is presenting at APHA, let us know so that we can make sure to cross-promote in the network so that everyone in the PBRN group knows that someone from a PBRN group is going to be presenting in such and such session and can try to attend that.
Right.
So APHA is such a mammoth.
I was talking about a different meeting, though, right? The one I'm referring to is the Connecticut Public Health Association. Right. We have our own conference.
Yes, and you're going to cover the PBRN model at that, right?
We're going to have a whole panel, the 2.5-hour panel on PBRN.
And that's great. Do you think that we might be able to post that online on the website?
I think, yeah, sure. I don't know that people would come to it. Obviously, it's a state thing, but you would be welcome to attend if you ever do that from the National Center. And also, but I was just looking for a set of slides if there's anything more current on the state of the field on PHSSR.
I know that I'm sure that there are some, I'm sure they have some down the hall as well that probably have some pieces of the research agenda that just came out and all of those issues. So we'll work with our our folks at PHSSR and with Glenn as well when he gets back to see what the most recent things they have and get those to you.
Great, thank you.
No problem. That's what we're here for. Are there any other questions that we can help answer or promise to find an answer to? Great. Well, we'd like to thank you all one more time for bearing with us as we work through the technical glitches of our first solo flight. Hopefully we'll have smoother takeoffs and landings next time, but thank you so much. And if you have any questions, we have posted the email addresses we talked about in the chat box. We really look forward to working with all of you. And don't forget, we have a July monthly meeting and we have a July virtual training webinar. Safe travels to Academy Health for those of you who are going. Take care, and thank you so much.
Thank you.
Bye.